Welcome everyone to the International Papillomavirus Society Educational Webinar Series of 2021. And today we're talking about a very interesting and actually quite controversial subject, HPV latency. And we've phrased it more questions than answers, and I think that's a pretty good description of the field. I am Margaret Stanley, the president of IPVS, and we have two speakers today. IPVS is the society comprised of people who are the global authority on papillomaviruses. And we have a simple mission. It's to contribute to the elimination of papillomavirus disease. And so it's about research, which this webinar is reporting. It's about education, which is part of the webinar. And we have a question-answer information center, the hub. And we have a truly international membership, more than 50 countries. And we're always looking for new members, so please join us now and become part of our community. Now, today's webinar has two speakers. Bettie Steinberg, who's a very distinguished virologist, and Patti Gravitt, who's a polymath, I always say, an epidemiologist of renown and an excellent molecular biologist. They will each talk for about 20 minutes, and you will have a lot of questions, and we'll have a 20-minute Q&A session after the talks are finished. So I think it's now time to move to the speakers. Great pleasure to introduce Bettie Steinberg, who's been in the HPV field from pretty well the beginning and who has a real interest and knowledge of this topic. Bettie, please.
Thank you, Margaret. It's really a pleasure to be here with you today. As Margaret said, I've been in this field a long time, not to date myself, but it's more than 40 years. So I've seen huge changes, and we have a lot more still to learn. Let me share my screen, and I will start my presentation. So as you saw earlier, the title for this session is HPV Latency, More Questions Than Answers. And that's true of much of science, because as I've told my students, when you do research, every answer comes with two new questions, at least two new questions. So we never run out of questions to ask. But what I want to do is give you a basic science perception on HPV latency. This is one model of how we think about latency and what it can do. This is by John Durbar. And in this model, you get an active infection, and then you get an immune response that causes regression of that lesion. And when it regresses, there's no longer disease, but there is still viral DNA present, viral latency, which can be reactivated to form a new lesion. And clearly, the key to all of this is the immune regression, eliminating the active infection, but not eliminating the latent infection. So how do we define latency? And as a molecular biologist, I define it, and this is the definition that I have published, I define it as the presence of viral DNA in clinically and histologically normal tissue with no detectable spliced message for E6 or E7. And those are the two genes that cause tumors. They cause all of the expansion of epithelium that causes even a benign papilloma. In addition to no splice message for E6 and E7, there are very low to undetectable levels of the other viral mRNAs. If we really push it to the ultimate by PCR, we can sometimes see a small amount of E1 and E2 and no detectable protein. we know that latent infection is universal in skin. The HPV beta viruses seem to infect everyone, and it's common in the genital tract and less common but real in the airway, because approximately 5% of people have latent airway infection. And as with John Durbar's model, and that was with an oral rabbit papillomavirus, it's normally held in check by the immune system. So let me start by talking about respiratory papillomas. They're a clinical example of HPV latency, and in fact, this is where we first published the existence of HPV latency, was in studying RRP. So RRP is a disease of the airway induced by the so-called benign HPV type 6 and 11. It's characterized by multiple recurrences following surgery, as often as every few weeks, in the worst cases, maybe once a month or once every 6 months, maybe once a year in patients with mild disease. It affects both children and adults, and it's rare with a prevalence of 2 per 100,000. So people talk about 6 and 11 being low risk, but they're not if it infects the lower airway, the lung especially. Overall, 3% of patients with RRP convert to cancer, but in the lung, it's about 85%. So in that tissue, 8, 6, and 11 are not low risk. The conversion is rare in the larynx, but if you radiate the patients, which was done in the 1930s and 40s to treat this disease, then you get about a 15% conversion rate. And we, as I said, first described HPV latency in RRP in 1983 in a paper published in the New England Journal of Medicine. So what do we know? We know that the latent infection is widespread throughout the airway of patients with RRP. In this process, we took biopsies of the trachea and the larynx from patients with laryngeal disease. These were people with no history of tracheal disease. We studied 61 patients, and we analyzed the clinically normal biopsies. We had 50 biopsies from the larynx and 71 from the trachea. So obviously we had multiple biopsies. And what we found is, if you look at the percent of patients who are positive, if you look at a single biopsy, it was around 40 to 45%. If you had multiple biopsies from the same patient, at least one of those biopsies would be positive. And so what this tells us is that, first of all, this latent infection is widespread, but it isn't in every cell. It's patchy, because a biopsy is 3 to 4 millimeters in diameter. And even with that many cells, only about half of them were positive. So the latent infection is in a small subset of cells, but it is widespread, because in these patients with only laryngeal disease, we had latent infection as far down as the carina, to the bottom of the trachea. And also, some of these patients had no laryngeal disease at the time that we did the biopsies. They had come back for an endoscopy because of scar tissue or other problems. One of our patients had been free of disease for 30 years and still had positive HPV in the trachea. And we also asked whether it mattered which HPV type the patients had, because some studies have suggested that 11 is associated with worse disease. And if the patients had HPV-6 historically in their larynx or HPV-11, you can see that the distribution of latent biopsies doesn't matter in the trachea. The differences here are small and not significant. So we think that latent infection is the key to understanding RRP. We think it's the source of recurrent laryngeal disease or tracheal disease if the patients have tracheal involvement, because all patients have that patchy latent infection. And recurrence is not due to spread of virus during surgery or at other times. The disease is due to focal activation of that latent infection. And we know that patients with RRP have defects in immune response to the virus. And that's a set of publications that have been made by our group. I've collaborated with Dr. Vinny Bonagura, who's the immunologist that I've worked with. And his group and other groups have shown that patients with RRP have defects in their immune response, which is why when they have activation, they don't immediately clear that infection. They have recurrent disease. But the mechanism of activation isn't known. There are suggestions clinically that inflammation can play a role. For example, it has been postulated that reflux may play a role. And as I'll show you in our animal model, inflammation definitely can play a role. And we think that you can't cure this disease unless you eliminate latency. You can only try to control it, and that means improving the immune response. So let's talk about an experimental model that we have used to try and understand this mechanism further. We've used the CRP model, this cottontail rabbit papillomavirus model. And when you dilute the virus and then you inoculate rabbits, and in this case, we were inoculating Dutch belt rabbits. These are these pretty black and white ones. And we inoculate the white skin so we can see better. When you dilute the virus, you start with a high inoculum, you get a wart. You dilute it to the point where you don't get warts anymore, but we tattooed those sites. When we come back 3 months later, those sites still have CRPV DNA present and no E6 and E7 mRNA. And these can be activated to form warts again, and I'll show you that data. So when we activate, and we've done this with multiple different modalities, including just taking a nail file or an emery board and rubbing the skin every day. Nothing that causes trauma that's gross, but it's hard to quantify rubbing with an emery board. So we used a low dose of UV, low enough to not cause any burn. And what you see is that 1 week after a single dose of UV, about 30% of those sites have detectable E6 and E7 RNA, and it goes up to about 40% at 2 weeks. And then it starts to drop down. And then the warts come up, but they come up later because it takes time after you turn on the virus to generate the warts. And you see that you get about 25 to 28% of the sites forming warts, which means that, and so obviously these are the sites we didn't biopsy, because if we take the biopsy, then we've removed that area. So it means that there are more latently infected sites than sites that give warts. In results that I'm not showing here, we've done some subsequent studies using multiple doses of UV, and then we get a higher rate of activation. So sometimes a low dose just isn't enough. So let me step back and tell you a little bit more about something we learned with our studies of respiratory papillomas that we then applied to the rabbit model. We've shown that COX-2 and PGE2 are expressed in respiratory papillomas. Here's the Western blot, the expression of COX-2 compared to normal laryngeal tissue from the same patient. These were matched pairs, and this is the PGE2 level done by ELISA. And PGE2 can affect the expression of HPV using cells in culture that have either HPV11 in them or HPV16. We actually used HeLa for this. You see that if you add PGE2 to the media, you increase the expression of the virus, of E6 and E7 mRNA, even though these cells are making PGE2. If you add more, you can push it up. And if you treat the cells with Celecoxib, a COX-2 inhibitor, the virus expression goes down. So we used that same model and asked if that's what was going on in our animal model. So COX-2 is expressed when you irradiate the skin with UV, both at the protein level and at the mRNA level. And picograms of PGE2, up to 1,000 picograms per milligram of cell protein, are present in that tissue. And then we asked whether it was required that COX-2 and PGE2 was present. So I'll walk you through this because it's a lot of data. So UV turns on the E7 mRNA, just like it did before. If we give the rabbits Celecoxib orally, because it's an oral drug, it's Celebrex. If we give them Celecoxib, we almost completely suppress the UV activation. If we do the UV activation and give them Celebrex, but we just put topical PGE2 on the skin, and we put it on in DMSO at the site of the latent infections, then we get activation again. It's not quite as good as the UV alone, but we rescue that inhibition with Celecoxib. But if we just put PGE2 on the skin with no UV, we did not get any activation, which means that just putting PGE2 on isn't enough. And what we've more recently figured out is that what you have to do is also increase the PGE2 receptor levels. And EP4 seems to be the key player. There are 4 receptors for PGE2, and in studies that we haven't published yet, EP4 appears to be the critical ones in an HPV-induced lesion. And so what you see is that within 24 hours, you see an increase in EP4 mRNA, and it peaks at about 48 hours. And that's at the same time that we started seeing marked increases in E6, E7 receptor levels with UV treatment. So clearly, in this model system, the E6 and E7 mRNA are being induced because we're inducing PGE2 expression, and then PGE2 is signaling through its receptor. Now, going back to trying to understand this, and I've been trying to understand latency for a long time, because as I said, I first published this in 1983. When we put biopsies of latent tissue from patients in tissue culture, it immediately turned on the virus. And so we could never study latency because we would get expression, even though we didn't have expression of E6 and E7 in vivo in the patients. But we started seeing it within 24 hours after we put that tissue into tissue culture. And I think that's because there's all kinds of factors in the serum that we have in our tissue culture media, and we're asking those cells to grow. We're stimulating them with lots of things to make them grow, which is what inflammation does. If we put Celecoxib into the tissue culture media, we could suppress the activation. So I'm at a point now where I'm not going to be continuing these studies, but I'm hoping that some of you younger people who are in the audience will want to study latency, And you might use this trick in order to get your tissues into tissue culture, where you can then manipulate turning on or turning off latency. So these are the major unanswered questions that I think have come to my mind. First of all, is latent infection established whenever HPV infects patients? Is the latent infection in stem cells? Where is it? We know it's not in every cell, and it's not even in every biopsy. And it seems that it would have to be in stem cells because it seems to persist for years. As I said, we had one patient in our study of tracheal latency who had been free of disease for many, many years, and she still had latent infection. What is that trigger for activation? Is it always COX-2 and PG2, or can other things do it too? And does activation happen frequently in patients with no disease, and then the immune system clears or suppresses it? Or is it a rare event? We have no idea how often it happens. And finally, do people ever clear latent infection? It seems that the immune system cannot, because there's no target for the immune system to recognize latent infection. But we don't know if you can ever clear it. So all of these are questions that I'm hoping you will address in the time to come. Thank you. I'd now like to introduce my co-speaker, Patti Gravitt. And Patti is an epidemiologist at NCI. She recently joined the National Cancer Institute, which is part of NIH. And I'm going to hand it over to you, Patti.
Thank you, Betty. That was wonderful. And I think it sets up really nicely what I'd like to talk about today. I have to just say that, I've admired Dr. Steinberg and Dr. Stanley's work for so many years as a young female investigator. So I'm really honored to be part of this panel. And what I'm going to do is to talk about HPV latency from an epidemiologic perspective. Specifically, I have no conflicts to declare, just to get started. But, what I wanted to remind us before I go on to this talk is that sometimes it's helpful for us to periodically reflect back on study results that may have been, generated 10 or 15 or 20 or 30 or 40 years ago, and really look at the data again, and maybe through multiple lenses and with different information, in order that we clarify the certainty of our inferences. And I really got emboldened to think about this from reading Adam Grant's book, Think Again, where he consistently kind of talks about the fact that, in society, once we hear the story and accept it as true, we rarely bother to question it again. And he keeps bringing back, but scientists do this. This is a scientific thought. And in general society, we should be more scientific in our thinking. And, so from that perspective, I said, of course we should. And that's what we're going to do today. So, what do we know? This is a very commonly shown slide from Mark Schiffman and Phil Castle, which accurately represents kind of what we knew at a population level about the natural history of papillomavirus infection in women and risk of precancer and cancer, burden of precancer and cancer across the lifespan. And I'd like to say what I think is unequivocally agreed upon is that HPV does seem to be acquired. And I'm going to talk largely about cervical HPV, but I think it probably extends fairly well, at least to male genital HPV infections as well. But that HPV is acquired really around sexual debut in the late teens and early 20s and becomes undetectable, or what we refer to as cleared, within 2 years in about 90% of women. I think that there's no debate on three fundamental issues, and I want to kind of get those out of the way. That individuals who have persistent high-risk HPV detection are the ones who are at the highest risk for progression to precancer and cancer, and I think that fact has nothing to do with what we understand or believe about HPV latency. I think we also understand that women who test negative for cervical HPV DNA are at a low near-term risk of precancer and cancer. So at least in the next 5, maybe 7 years, their risk is probably going to be very low. So again, this does not question our current management protocols, even if we start to understand a little bit more about latency. And finally, women and men who have new sexual partners, given the high number of HPVs, the types that circulate in a population, all of them are at a higher risk for new HPV detection, no matter their age. So I think we can all agree on that point as well. So what are the unknowns in this pathway? And I really want to focus on, what is really happening to produce this residual HPV prevalence, which if you look at screening programs is anywhere between 10 and 20% of women over the age of 30 will still have HPV detection and screening now that we've started to look at screening in a wide variety of populations. And so why is that true? Is this just reflective of long-term persistence? We just didn't know about it because we weren't screening for HPV in the past? Is it continued accumulation of new infections? Is it due to reinfection from partners? Or possibly is it due to reactivated latent infection? And so I wanted to really highlight the issues that we think maybe require some clarity. And this is, again, where we're going to start looking back on the data that we already have and say, can we get any more clarity if we kind of look at it from this lens? And so one issue is when HPV clears, or in other words, tests negative, what does that infer about the infection status in that woman? Does that reflect eradication of the virus from the individual or immune control, as Dr. Steinberg has talked about? And then there's some questions about whether that immune control actually represents, virologic latency as was defined earlier, or just a really low viral copy number or low viral gene expression that is just below limits of detection. The second issue is what proportion of a newly detected HPV in a population reflects acquisition, reinfection, reactivated latent infection, possibly just deposition from a recent sex act that doesn't even result in infection, or maybe even autoinoculation from another infected site. And finally, is the risk of precancer and cancer the same, given which of these different pathways originated to get the new HPV detection that's going to be clinically managed? And so I want to take a little detour here and just before we look at the actual data that we have epidemiologically, and remind us that, we're talking about observational, non-experimental studies. And so there are always challenges and interpretation and inference that we make from HPV natural history studies. I want to first clarify that we think that when we were looking at HPV patterns in order to classify them as exposures, that then leads to risk of disease endpoint, which led to a lot of our interpretation of HPV patterns. I think those were all really good definitions as exposures leading to disease within the confines of the time span that we were doing the HPV studies. But what I want to try to highlight today is that it actually is a little more nuanced and a little bit more difficult to make these inferences when we're trying to understand within women natural history of for example, the infections they may acquire in their late teens and early 20s over their entire lifespan. And so to illustrate that, I want to highlight one important thing that I think is just critical for us all to recognize, is that when we're doing epidemiologic studies, we're measuring HPV detection, and that does not always, we think, represent whether an individual has infection with that type. It's just, do we detect it in the type of sample that we take, which is usually a cervical swab. So this is just an example of a fairly typical natural history study. This one would be a 2-year duration where women are sampled every 4 months over the 2-year for the detection of HPV. Women may enter the study at any given age. So let's say in this hypothetical example, they enter at 18 to 65 years. And then what we're looking for to look at the natural history within women is to look at type-specific HPV DNA test results over the study observation period. And so, just to give some examples, here's subject 1 who enters the study, who's DNA negative for a type, becomes DNA positive for the type at 8 months and persists with that detection. And so we would consider that someone who acquired HPV and persisted throughout the study period. Subject 2 entered the study with a positive HPV DNA test result, became DNA negative and persisted with that negativity throughout the study period. So we would consider that to be a woman who cleared their infection. Subject 3 enters DNA negative, becomes DNA positive at the 8-month visit, persists through the 16-month visit, and then is DNA negative again in the final 2 visits. And we would consider that within the study period, we've observed a woman to acquire and clear HPV infection. And then you have these patterns that we're increasingly recognizing in subjects 4 and 5, where, for example, you may enter or acquire HPV, go through a period of negativity, and then become positive again for that same type. And so we can call that recurrent detection. Sometimes we may call this just a false positive. Sometimes we may call this a false negative because maybe we just didn't sample correctly. And so in some studies, we might say that this was actually a 1-year persistence rather than a clearance and recurrence. And then finally, in subject 6, this is the majority usually of subjects who enter and remain HPV DNA negative throughout the entire study observation period. So now in making these interpretations of these test patterns, I think we have to really think about what we know, this is what we observe, but then we really have to interpret that in the context of what we don't know. So importantly, we don't know the testing history that would have been every 4 months from these women before they entered the study. And obviously, the older they are at study enrollment, the more likely they've had some of these other patterns before we get these just limited observed patterns over 2 years. Second, we don't know what happens in the 4-month interval between the study visits. Do they ever become positive and negative between these study visits with like short bursts of reactivation, for example? And we also don't know their test status after a study ends, right? So particularly for things like, this woman did not have a recurrent infection. Well, we're not sure that she didn't. We just stopped testing for it. And so with that in mind, we can think of reasonable and plausible alternative interpretations. And I want to emphasize that these are non-mutually exclusive options, right? And the reality is we can't know with certainty which ones are true. We can only look at circumstantial evidence and think about the probability that each one are true. And that's what I'm going to talk about in the next few slides. But for example, here, where we consider this woman uninfected and then acquiring this type-specific infection and persisting through time, this could also be the recurrence of a previously acquired infection that we just had not seen because it was before the observational period. Similarly, this subject 2, who looks to have cleared infection, may just have gone into a period of immune control. And that could be the same kind of thing. We could think about this as true recurrence and immune control versus acquisition and clearance, and all of these patterns. And then importantly, in subject 6, who we consider to be an uninfected woman, well, she just may be having a well-controlled type-specific infection that was just never reactivated through the entire study period. And I'm certainly not trying to imply that that is always the case when you see women who are consistently negative. We definitely know that these women are at a low immediate risk of any kind of disease. And a lot of even these transient detectable patterns don't carry high risk of immediate disease because certainly they seem to be having a healthy and appropriate immune response. But I think it is important for us to kind of consider that we aren't really certain about what these transitions between positivity and negativity actually imply about whether a woman currently does have an infection and what that infection, even if well controlled, means about her entire lifetime risk of developing precancer and cancer. So what do we know in humans about this subject from observational data? Well, we do know that if we start looking for recurrence, it's not really uncommon, even in short follow-up time periods. So this is just a study from one of the early Gardasil trials in the placebo arm and in young adults. And you can see when they looked at type-specific infections that had appeared to clear during study follow-up and then reappeared by 12 months, 24 months, or 36 months, on average, about 8% of the apparently cleared infections recurred just within the short time frame of 3 years. I want to make a really important point that, one of the things that's difficult, as Dr. Steinberg presented and John Dorbar has in the past, in the animal models, when they inoculate and for example, get the low copy inoculation or low viral titer inoculation, they don't get warts. They know where they were infected because they can tattoo it. So we don't have that, yeah, unfortunately, in observational studies, we don't have the ability to look at that. And so we have to kind of use surrogate measures to understand who's at risk of reactivation so that we can know, if we can't really have the power to study type-specific recurrence, can we look at when we just see new infection, what's the likelihood that it's acquired versus reactivated? And one of the things that's important to note is that reactivation, a woman's risk of seeing a reactivated infection is conditional on how many types of HPV she's acquired and is currently harboring as latent infection, and then how dense the foci of latent infection is, as Dr. Steinberg had kind of pointed out a bit in the RRP model. And so this is just a study that we published in a cohort of mid-adult women in Baltimore City, fairly medium to high socioeconomic status. And we looked at, how many HPV types did they test seropositive to out of just 8, according to their self-reported number of lifetime sex partners. And you can see there's a pretty linear association. So while we often say 80% of people will acquire at least one HPV infection, I think that's true. But I think it's also true that the more exposures you have to new HPVs, the more types you'll accumulate. And so that means the more you may be harboring as latent infection, and the probability that any one or more of them might be detected, newly detected or newly reactivated at any given time is higher in this group versus this group. So we actually looked at cumulative incident infection in the women with 5 or more lifetime sex partners versus 4 or more, just to kind of think about that relative probability of new infection if reactivation was actually a significant proportion of the risk. And what you can see here, when we look at this is the baseline prevalence of HPV in women who have 5 or more lifetime sex partners, and on the bottom 2 figures of those who had less than 5 lifetime sex partners. You can see clearly that the cumulative HPV detection over time in this 2-year follow-up study is 2-fold higher in women who had a higher number of lifetime sex partners. And importantly, when you compare in each of the groups, those women who are sexually active but with no new recent sex partner versus those who had no recent sexual activity, there was not too much difference. And this implies that deposition from a recent sex act reinfection, male partner behavior did not contribute substantially to the new infection. Sorry, I mistyped that. And so another similar study, but with much younger women who are a median of 15 years of enrollment, and followed these women fairly frequently every 3 months over time, found that 23% of type-specific detections cleared and were redetected during study period. And that's over about a 6-year follow-up. And you can see that it was a fairly long mean duration of detectable runs versus mean duration of non-detectable runs. And in this study, they actually took some HPV positive women and re-enrolled them several years after the initial cohort. These are people who were 16 positive in the original cohort. They re-enrolled them sometime later. And about 40% of those women had HPV-16 redetected at the re-enrollment, and the median time from last detection to redetection in the re-enrollment was 7 years, and the interquartile range went up to 11 years. And so I think these data taken together suggest that HPV infection duration is probably much longer than previously thought when we were only looking at duration based on detectability. And again, I think this is fairly consistent with what Dr. Steinberg reported with the RRP data. And finally, what happens in that study interval that we never look for? So in between our interval samples, what's happening with HPV types in that interval? And we took advantage of a study by Rebecca Brotman, who had looked at women self-sampling for 2 to 3 times per week for 4 months. And we looked at HPV. These are relatively older women, nothing particularly high risk, not HIV infected. We saw a few things that were important. One is that the more samples you take over an interval, the more types you'll detect per woman. So if we only look at one type, one swab, a woman might have a median of 2 HPV type-specific infections. If you look at the cumulative type-specific detection over all of these swabs combined, taken over a 4-month interval, the cumulative number of types increases to 4. And the interquartile range, again, goes up to 7 types per individual. And so given that, if you were to just take a single cross-section at any time to define someone's HPV infection status, you would probably underestimate their HPV status and true infection status by about half. In this study, where we're sampling so often, the median duration of detection was really small, about 7 days. And we did look at detectability based on their sexual activity that they were collecting and reporting on daily diaries, and did not find any association with sexual activity. So I think that these data are consistent with the animal models that you just seen, which report short bursts of reactivation and rapid immune control in a kind of normal situation and healthy immunity. And the lack of association with sexual activity in the HPV detection in this study, I think, reduces the likelihood that recurrence is due to reinfection or to deposition from a sex act. And so what this does imply, as we said, is that it's associated with immune control. And so what evidence do we have that immune control is important in kind of suppressing reactivation of controlled infection? This was a seminal study in 2005 by Howard Strickler with the WISE cohort, where he compared HIV negative to HIV infected women with decreasing CD4 count, or conversely increasing immune suppression. And what they found in this study, looking at women who were sexually active in the 18 months before study follow-up versus those who were sexually inactive, that HPV new detection increases proportionately with increasing immune suppression in both groups. And the relative excess risk that you see in the sexually active versus the sexually inactive women gives us some sense of the proportion of women whose newly detected HPV is from possible acquisition or reinfection versus reactivation. And this definitely supports an inference that large proportion of new HPV DNA detection in adult women represents a loss of immune control of persistent infection, even in the sexually active women. So kind of our current thinking, and this is modified from John Dorbar's recent talk, is that HPV maybe doesn't always clear, but can be controlled by immune surveillance. Certainly over time, immune suppression can lead to reactivation of controlled infection. And I think it's important to realize immune suppression may be transient, waning, chronic, systemic, and local. And importantly, and I think this is a really critical point, latent or controlled low copy infection is not associated with short-term disease risk. That's not controversial, I believe, with the large number of observational data to support that. But the important difference is if immune control wanes, or if it's suppressed at any time and results, as seen here, in persistent DNA detection, then the risk of progression to precancer may increase again despite a long history of periods of control. And so again, getting back to one of Bettie's questions, is clearance feasible? I think it's nearly impossible in humans for us to either confirm or deny when with viruses cleared or has become latent. In a small study that Ann Hammer has published looking at tissue sampling of each individual little section of 2 entire cervices of women who tested HPV negative on an exfoliated swab, which is how we usually define, we see exactly what Dr. Steinberg has shown you in the RRP patients, where you have incredibly focal HPV infection in the tissues. This gives us molecular evidence that HPV DNA can be in a cervical tissue without being detectable in screening. And as was brought up before, I think it is important for us to think about whether focal detection supports the possibility of a predilection of latent infection in a limited number of maybe stem cell-like basal cells. And that would be a really important research question, I think, to address. So getting back to our original unknown questions, we ask a lot of these questions at the beginning, and I think the answer is yes, probably all of these are possible. I think what we don't know is how often each one of these kinds of events contribute to a new detection, and who is more likely to have one versus the other. And this is just a quick figure to say that, if we look at the accumulation of our data, and we've got these 2 kind of natural history pathways. One is that true uninfected can acquire HPV, either clear it or control it. And if it's controlled, it could go into either reactivation back to latency and cycle through, or it could lead directly to clearance. These things are going to be associated with the following HPV patterns. So an infected B negative, acquired would look positive, but also acquired would look HPV positive, or reactivated would look HPV positive, and then clearance and latency would both look like an HPV negative test. And I just want to say that it looks like the younger you are, the more likely you're maybe looking at acquired infection, although it's not impossible in the older populations, but certainly the older you get, the more likely a newly acquired DNA detection would reflect latent reactivation. So kind of to conclude, I think it is time for us to think about this latent infection DNA detectability cycle in our natural history pathway. Some of the knowns we can now say from both what Dr. Steinberg presented and what I've presented is looks like HPV definitely can hide in basal cells in the tissue without replication or being detected on an exfoliated cell. We do seem to see that incident detection of HPV may represent either reactivation or recurrence. Type-specific recurrence could reflect latent reactivation, and I believe the data are most consistent with that explanation. Could also reflect reinfection or autoinoculation from another site. This is an area that we really do need to study a little bit about the proportions. And recurrence and reactivation is associated apparently with immune suppression, either systemic or local. And again, the unknowns, coming back to that statement, what proportions of new detections represent acquisition, reinfection, reactivation, autoinoculation? Does it vary by any factor like age or sexual history? We don't know, does HPV ever clear? We don't know what determines clearance versus immune control, if that's true. We're not really sure how long latent infections can last, although we have an idea they could last fairly long periods. We should start looking, based on some of the data that Dr. Steinberg presented, can reactivation be controlled iatrogenically? You know, is there something that we can do to rebalance a dysregulated immune system to push HPV infections back under immune control rather than doing extreme kind of excisional therapies? And then is there a difference in risk of cancer following a new or recurrent detection? So the implications for recurrent positivity, why does this matter? Well, as I think somebody has already asked in the chat, you know, what role is there for prophylactic vaccinations in adults, given a higher proportion of new detection is attributed to reactivation? Can this actually help to suppress reactivation? Should we better understand risk factors for local or systemic immune suppression so that we can design better interventions? Is there a lifetime risk of latent infection? Or if there is a lifetime risk of latent infection, should we reconsider the age we are exiting women for screening, given that we know that immune suppression increases with age? And is accurate communication of HPV detection risk important when we're screening women so that we can reduce some psychosocial anxiety, for example, concerns of infidelity? And so I'm just going to end by saying that the IPVS Policy Committee does believe that these are important questions. They're supporting a State of the Science Working Group on papillomavirus latency, which we hope to make available publicly in the first half of 2020. And the outcomes of this are really twofold. One is to make sure that we can identify common language to explain the nuances of within women natural history and our certainties and uncertainties. And second, to prioritize the most consequential uncertainties for further research, because I agree with Dr. Steinberg, there's a lot more to do, and this is a really, I think, ripe field for new investigators to move forward. And so with that, I really thank you for your attention.
Thank you very much, Patti. And Betty, that was absolutely excellent. Now we've got a lot of questions, but I'm going to start with the question that you've referred to, Patti, and it applies to both you and Betty, and it's about vaccination. And Anne Birchall has just posted the last question, but it reflects probably 6 or 7 other questions in this list. What role may HPV vaccines have in mitigating the reactivation of latent and undetectable infections? Are there data from these cohorts with close monitoring? Now, it applies very much, I think, to RRP, because there are anecdotal reports in the literature of immunization to reduce the number of recurrences and reactivations of clinical disease. And it's also extremely important for genital infections, because I would turn this question round and say it's not about mitigating reactivation, but it's about suppressing transmission. Does the mucosal antibody actually prevent transmission by neutralizing virus at these surfaces? So I'll ask you first, Betty, because RRP, there's data out there. Whether it's good or bad, I don't know.
So the data on using Gardasil or Cervarix to treat an current active infection is equivocal. Some people have reported positive results, but none of those studies have had placebo controls. And there is a strong placebo effect in any disorder that has an immune system involvement. And clearly the immune system's involved here. So until we do the right studies, which means placebo-controlled vaccination, we won't know if that really makes a difference. The other part of this is that theoretically, just having antibodies to the capsid shouldn't be any protection in terms of latent infection. But if you also had some T cell response in your vaccine, to your vaccine, then theoretically it could have an effect. Because if you have both antibodies and a T cell response, the T cells could respond when that cell becomes activated. And clearly from the data from Australia, if you vaccinate people young before they're infected, you will prevent the initial infection and you will reduce the risk of any HPV-associated disease. There was a clear reduction in the prevalence and the incidence of RRP in Australia, because one of the ways that this virus infects babies, and half of the patients are babies, is they're infected at birth or prenatal exposure in utero, but mostly at birth, to being born to a mother with a genital tract infection. So if you prevent the mother from ever getting infected in the first place, you will prevent the baby from being infected.
It's also been shown in data from Canada. The Canadian data supports that also. Patti, what do you think about this question?
Yeah, I think we can theorize all we want. I think it probably needs a formal trial, because I think all of these things are theoretically possible. I think that, I don't see, from my limited immunologic understanding that the, antibodies induced to L1 is really going to affect a latent virus in the basal cell, which is not really expressing anything. I don't think that's going to stimulate immunity, but certainly one could imagine that it would prevent lateral spread. So if we looked at that hysterectomized tissue and you saw that one patient who had HPV-18 kind of all around different foci of the cervix, and the number of foci being associated with the likelihood that another one of those foci would reactivate and become disease, I can see where that is a plausible explanation for why kind of vaccination could prevent recurrent disease at least and lateral spread. But
that would require auto-inoculation.
Yeah. Mm-hmm.
Not just activation from latency.
Right, exactly. It would require, right. So that's the thing. It wouldn't necessarily prevent reactivation from latency, but it could prevent the lateral spread and auto-inoculation around the cervix and thus reduce the risk, because you would ultimately reduce the number of foci of infected cells over the lifespan. But I think this is, it's very, very unknown. And to date, we've not really seen, too much evidence of prevention of reactivation, particularly when you look at the vaccine trials in HIV-infected individuals who seem to reactivate quite rapidly.
There's a question here from Christine Bellis. She says, how might reactivation patterns differ among women who underwent definitive therapy for lesions? I guess she's looking again specifically at the cervix.
Yeah, so we've looked at that actually, and we do see a somewhat lower risk of reactivation, let me say, when we're just looking at incident new detection in our mid-adult women cohort, if you have had excisional therapy, you do have a slightly lower risk of reactivated infection. And that certainly seems true, for example, in men who are circumcised, who have a major excisional procedure to get rid of probably a lot of latent infections, and they have a much lower risk of new detections over time. So I think that you probably do, with treatment, reduce the I'm going to not say probably, it's possible that you could reduce the entire latent reservoir through different kinds of therapy, both ablative and excisional.
Well, this leads me to ask another question, which is, so far we've been talking about latency in actually either the larynx, in the cervix. We're all targeting fully differentiated squamous epithelia. Now, if you start looking at the cervix, I can accept that there's probably latency in the squamous basal epithelial cells, but the question is, how can you be certain that there is latency in these cells at the squamocolumnar junction, where we know there's actually there are different sets of cells with different markers and probably different differentiation routes. So, do we need to have is the squamous basal cell the target cell for the HPVs that undergo latent infection? Or can any cell in that system, and I mean in the basal layer with a stem cell-like property, harbor HPV episomes which can reactivate?
Well, we know in RRP that the trachea has latent infection, and the trachea is not a squamous epithelium. It's a ciliated columnar epithelium. And my suspicion, with no solid data, is that you get latent infection in that tissue, and it's a non-permissive cell. You don't get expression of E6 and E7 because it's the wrong cell, but the virus persists in that cell. And we know that you can induce metaplasia of the trachea to a squamous epithelium. That epithelium, unlike skin, no matter what you do to skin, it stays squamous. But, it might get thicker or thinner, but it's still squamous. The trachea undergoes a metaplasia, it redifferentiates, in part due to things like retinoid responses. But I had a resident who did a project many years ago where he did tracheotomies on rabbits. And when he put in a trach tube, he got squamous metaplasia throughout the trachea, not just at the side of the trach tube, all the way down to the carina very quickly. And these areas got bigger with time. When he removed the trach tube, it reverted back. We know that one of the risk factors for having tracheal disease with RRP is having a tracheotomy. So it may be that you get the infection into stem cells of the wrong type, or maybe just that you're in the wrong type, and therefore you can't express. But when you undergo metaplasia, then it becomes a squamous cell, then the virus can be activated. It may also be possible that stem cells are non-permissive. In their quiet, stem cells don't normally divide. They sit there very quietly most of the time. And maybe in the stem cell environment, that's a non-permissive cell. And it's only when the stem cell gets stimulated to divide, which happens with any irritation of the surrounding epithelium, then you call up new cells, then you get reactivation. And these are all questions that we need to study.
You've just described very beautifully Epstein-Barr virus in its latent form. So I think lessons from other viruses, particularly the herpes viruses, will shed a lot of light, certainly on immune control in the genital tract. I hate to say this, but we've come to the end of this session. It has been absolutely fantastic. Thank you both for really quite splendid talks. Now, there's so many, many questions that I can assure you they will be answered from the Q&A by email or by correspondence in some way. So thank you again. It's been a real privilege to hear you. And I've got up here a marketing message for our next webinar, which is different, and it's about behavioral research and HPV infections and responses to treatment. Thank you very much indeed, and thank you everyone who's listened.
Thank you.
Bye-bye.
Bye-bye, everyone.